Welcome to The Better Life with Dr. Mary Ann Pinkston. Join Dr. Pinkston today as she teaches you how an integrative approach to health, combining holistic and contemporary medical information, can lead you to the better life. And now, here's your host, Dr. Mary Ann Pinkston.
Hello, everybody. Welcome to The Better Life with Dr. Pinkston. I am Dr. Mary Ann Pinkston, and today, as usual, I have a fantastic guest. I'm really excited about this doctor that's with us. It is Marschall Runge, Dr. Marschall Runge, who is actually Dean of the School of Medicine in Michigan and CEO of Michigan Medicine, but also VP of Medical Affairs at the University of Michigan. Does a lot of work with Michigan, but knows my husband's Ohio love, and but also got his MD from Johns Hopkins, did cardiology fellow at Mass Gen. But I think the most important thing is he's a Texas native. So there you go. Right, Dr. Runge, good morning. Welcome. I'm really excited about this topic. Everybody who's near and dear to me knows that I love to discuss the future of medicine, how things have changed, how they are now, and where they're going. And you are absolutely at the top of the food chain, maybe I'll say, on knowledge and direction here. You have a wonderful book that you've written, The Great Healthcare Disruption, I think very appropriately named. And so welcome. I am so happy to have you.
Well, thank you, Mary Ann. It's great to be on your show. A real privilege. And thanks for your very kind comments.
Thank you. Well, we had a great discussion kind of before getting started, and you do have some great roots in Texas and all. So I'm glad to have you on today as well. So let's get started. The Great Healthcare Disruption. I guess give us a little bit of background on your story and how this topic became important to you.
Well, I've spent far more of my life in healthcare than anything else. I have been in healthcare for 40 years after training, and seen it from a variety. I'm a cardiologist. Seen it from a variety of angles. As I've had more and more administrative responsibilities, particularly in the last 10 or 15 years, I've realized that there are just fundamental issues in healthcare in the United States that we could make better. Easy thing to say, hard thing to make happen. But I got contacted by Forbes Books, which is a great publisher, and they said, "Hey, would you write a book on healthcare?" And I said, "Okay, what about it?" They said, "Whatever you want." So when do you get an offer like that? So I said, "How about if I write about in an optimistic way where I think healthcare might be going or where it could go in the United States?"
Good. Well, that's fantastic. And an optimistic way is good because I think there are not so optimistic views of it. I tend to get into that rabbit hole too. I tend to get frustrated as a physician and as a patient. I've been both now. So it is, and it's great that it is an optimistic view. So what are the major topics that you kind of hit on that you feel are most important to our future in healthcare?
Well, I think it all starts with us. And when I say us, I'm as healthcare, as doctors, we're part of that, but really the people. And yes. How do we improve health in the United States? And there are lots of different ways health is measured. But when you get to the bottom line and look at what I think is one of the best indicators, which is a measure called healthy average life expectancy, this just shocked me. When I started doing research for this book, I thought, well, we're probably top 10 anyway. But we rank now about 60th in the world, and comparing us to other countries. I mean, I find that almost unbelievable.
I do too,
There's a great group of epidemiologists at the University of Washington who provide some of this data, and they said, well, if their conclusion, which was published in one of the best medical journals, was that if we don't start making changes, although our life expectancy might increase a little bit over the next couple of decades, by 2050, we'll be 110th in the world.
Right.
And so, we just have to, and it's a hard thing to do. I mean, there's nothing easy about being a patient. There's nothing easy about being a policymaker. But I think with voices like yours, we can perhaps have an impact. And I think that's where, and there's lots and lots of potentials. so much of the innovation in healthcare in the world comes from the United States.
Right.
And,
right. Yeah.
So that's why I'm optimistic. I think we have the potential. I'm not willing to, fold my cards and say, okay, well, it's over.
Right.
So that's why it's a privilege to be on your show.
Well, thank you. And I hope you have that optimism and will to work hard at it. My son declared now that he wants to go to medical school.
Oh, good for him.
Well, I have to tell you, I actually had some reservations about it.
Yeah.
And I told him, I said, and I think my reservations come from my own just perspective of what I've seen in the last 25, almost 30 years now of practice, because I did the private pay work for a while and transitioned into MSOs and insurances. And that really took the air out of my, out of my professional heart, I guess. It really was deeply personal. And it was more of a change of the garden power, where I felt like I had all of the power to help my patients and do what I felt was right. First do no harm and do what was right. And then it turned into more, now I feel like, there's been so many years and I'm skipping so many steps, but now more of a corporatization. And that is where I have the biggest, I guess the biggest argument. How do you see it? That's kind of my perspective, but how do you see it?
Unfortunately, I see it very similarly. So the first thing I'll say is, everybody knows. I just talked about how terrible our healthy average life expectancy is, but everybody knows that the United States spends more dollars per person than any country in the world by a long shot.
Yeah.
So this is a little bit of a tangent, but so why is that? Well, it's because it's gotten corporatized, as you said.
Right.
So one interesting bit of information that you can look up, you can look at whatever your favorite chat GPT is the administrative costs of healthcare. And I'm going to say something that I'm sure you know, but your audience may not. So when you look at the administrative costs of healthcare, and what that means is how much of the healthcare dollar is coming out because it's going to some entity that is running that healthcare. Right. An entity, by entity, I mean insurance companies, commercial insurance companies, or federal government programs. So the dogma you hear is that the federal programs are inefficient and way too expensive. The reality is that commercial insurance companies in the United States, their administrative costs, and this is not counting the costs related to pharmacy benefit managers, their administrative costs are about 16% on average. Mm-hmm. If you look at another similar country, take Germany or Switzerland or Norway, their costs are somewhere between 4 and 8%.
Wow.
But then, and this was a total shock to me, real seriously. If you look at the administrative costs of Medicare, 2%.
Run that too, right?
So, I've spent a lot of my career, the practice, I've had a blended practice of private practice and practice related to my roles, but I've spent a lot of it in federally funded healthcare. So Medicare is one, but there are a group of clinics, I'm sure San Antonio's has these called federally qualified health centers.
Yes.
I worked in one half a day every other week for, not a lot, but they needed a cardiologist, one in a rural area in North Carolina when I was there.
Right.
And both the brand of medicine, the medical home that they build is fantastic. And the people who are there are doing it for the mission. I also have had opportunities to work on one of the Indian Health Service, one of their sites. The one I went to is Shiprock, which is a beautiful place, Shiprock, New Mexico.
Yeah.
And it's the same. I mean, they have great clinicians, great providers. They're dedicated to a mission. The Navajo, in that case, the tribal members don't have to pay a penny for health care. Now, that they've earned it. They merit it. But the government can run really great healthcare programs, but you never hear that. And what you hear is how great, if you join this insurance company, they're going to give you a free health club membership. It turns out, and this, I uncovered so much dirt in writing this book. So it turns out that they actually profit from that because they can cut a deal with a fitness center where they can enroll 1,000 people, and the fitness center knows that those 1,000 people, how many are going to show up, how many are going to use the fitness center, and so they offer that as a benefit. They actually get paid to offer these benefits. And one thing you understand, and then I'll stop jabbering on. One thing you understand far better than most people is that is not what helps people get healthier. Correct. That's not what helps people lose weight. It's people like you who take a personalized approach to healthcare and understand, there's so much more than saying, oh, here's a membership. Correct. So I just think we can do all these things better. Now, with the political environment, either before or at present, that's just not in the cards. Oh, and you mentioned one other thing, that I wanted to comment on. I read a really great article in the last week that talked about the fundamental issue that for so many decades, healthcare decisions were being made by physicians or other healthcare providers between them and their patients. Now they're not. They're being made by insurance companies and what the insurance companies will pay for. Absolutely. And Medicare falls in that same gap as well. It's whoever's paying now is dictating healthcare. For example, we talked a little bit about how much of a fan I am of the GLP drugs, GLP-1 drugs. Well, I think they're going to have a long-term benefit. And if your healthcare costs will go down if you use those to control many different things. But the insurance companies and Medicare won't pay for it because they're looking at the short term, saying, "Well, how much is it going to cost me this quarter?" Correct. So we just have a lot of opportunity, but it's so hard to help people understand that because you get these little blips on the news.
Absolutely.
With that, I'll pause.
Well, no, you're fine. You're very interesting. And I feel like now that kind of my perspective of it, having been in private practice and owning my own practice, very different than working salaried, for someone. And you're right about the administrative costs. They're astronomical. And that is most of where I spend, the money. People think it goes into my pocket. It absolutely does not. Right. I pay all the bills. I pay all the staff and everything first. Whatever's left over is mine. And at times my nurse practitioner gets paid more than I do. So it's an interesting, the administrative cost is one thing, but I find I function very well with Medicare and Medicaid and that they are easier to work with. I don't have to ask a lot of permissions about, I know how much it costs. I know if it's, where the cost is coming from. I know the rules and it's very easy. But when we flip into the insurance, it really is all profit based. And so that is the division, the government side of it, except for the reimbursement's very low, the government side of it really doesn't bother me. I actually would rather work with that. The insurance side, though, and the kind of the profit mind that goes behind it is where I find not only the least satisfaction, but the least, I guess, the least ability to provide quality care to people who really deserve it, no matter who it is that walks in my door, and experienced that myself under my own insurances. And I'm lucky that I know all the loopholes with my with insurances, right? And I know how to foster that through the doctor's office and their employees and whatnot. I know how to get around that, but a lot of people don't. And that's to their, to all of our detriment for sure. But yeah, oh my gosh, you brought up so many points that I wouldn't even know where to start. But I think the decision making, one thing I really enjoyed hearing you say is that the decision, but I guess you pointed out that is very important, is the decision making, is taken away from me and my patient in the room and guided by somebody else who looks to a profit instead. And that is, I think, the biggest debilitation. People also discuss too the pharmaceutical industry being so expensive and so, bottom line driven as well. And so I guess there's a mix there. Do you have any ideas? We're kind of jumping straight to the end now. I don't mean to. There's a lot in the middle. But do you find that there's a good solution What is, how can we be solution driven at this point?
Well, I have a couple of comments. I'm not sure I have any solutions.
Please.
But starting with how did we get where we are?
Right.
And it's been an evolution, and you describe it very, very well. But as an example, I will tell you, and I'm sure you know this, a little factoid that your audience may not know, is that we talk a lot about AI in healthcare.
Correct.
Well, the first entry of AI in healthcare has been around for a while, several years.
Yes.
And it is the use of AI by insurance companies, and that's how they drive these high denial rates that we all know about.
Absolutely.
And, many people and many providers just give up after a while because no matter what you do, you don't seem to be able to make progress. And the reason for that is it might take me or you or our assistants hours and hours to go through a single medical record and look to see, did we all meet the criteria that they say we have to meet to be paid and for the patient to get that benefit. Meanwhile, the insurance company plugs it in, 15 seconds. Everybody knows how fast ChatGPT is.
Right.
In no time at all, it says, hey, we found these 5 areas where it's not meeting the criteria, so denied. They don't tell you what those are.
Right.
They just say, not meeting the criteria.
Correct.
And a human being on the other side, and up until very, very recently, has had to try to figure that out. Mm-hmm. So that's part of the problem. I think another part of the problem is that we have to be thinking about healthcare as a long-term project.
Right.
So, for example, much of healthcare is paid for, as I mentioned before, in little increments, and nobody's really thinking about the investment. So let me give you my analogy.
Absolutely.
We both, I don't currently, but have lived in Texas. Texas has great highways, really great highways.
Really, yes.
But who would pay for those highways? That's a government function. We pay taxes and we get great highways.
Right.
And I think healthcare is exactly the same. We pay taxes and we ought to get great healthcare because when you think about it, and I'm sure you will probably not so much with your patients, with the patients I see, their health declines and then they end up in the hospital for a month. Mm-hmm. And they need all kinds of complicated care. Mm-hmm. And if we started thinking about that more in terms of prevention, which I'm sure you do, but if we could think of it nationally as prevention, how do we get people in better health? Yeah. I mean, we could do that.
Yeah, we could.
One of the crazy ideas I heard, which has been tested actually, and has had modest results so far, was instead of requiring that whether it's Medicare or insurance companies, Medicaid, whoever it is, provide gym benefits. How about if they provided delivery of healthy meals? So you couldn't do that for 3 meals a day, but you could get that. And some of these, I haven't bought them myself. I should, but these healthy meals you can get are great. And that might help people shift. The last thing I'll say about just in the purely preventive manner, one of the countries in the world that ranks really high is Singapore. Right. So Singapore is, why are they so high? And it's really structured. And in fact, one of my sons was working in that part of the world, had the opportunity to go to Singapore, and he said, Dad, I can't live here. And I said, why is that? And he said, well, do you understand that you can be arrested for bringing chewing gum into the country? Because they keep everything pristine. Yeah. But what they do also in terms of health is they've made it impossibly expensive to own a car. So it's like $100,000 a year when you include insurance and
wow,
driver's license, $100,000 a year.
Wow.
So Singapore is really different than San Antonio, for example. You can't walk all over San Antonio. But, it helps people do much more walking, just regular walking. Sure. The other thing they do is they tax what we'd call either junk food or highly processed food. Cheetos, pick your favorite one that you can't put down, that food chemists over decades have made it so you just can't put it down. They tax that at a very high level.
Wow.
And then, so I don't know what the numbers are, but if a bag of Cheetos costs $3 here, it might cost $20 there.
Amazing.
And they take that money. So partly that discourages people, but they take that money and they make healthy food inexpensive, really inexpensive.
Yeah.
So
Yeah.
could we do things like that in the United States? I don't know. Bloomberg tried to get rid of the huge fountain drinks in movie theaters in New York, and he's a guy who gets things done, but he couldn't get that done.
Get that done, boy! I'll imagine. Wow, it's like taking guns away in Texas. I bet it's just not going to happen, right? So I know, and I think what I have dealt with people in trying to take a preventative role most of the time is cost, and that cost somehow can be distributed in a different manner for people to afford what they need, to the tools they need. A good dietitian, a trainer, somebody to help them in their fitness goals. Not everybody's healthy and can just go out and run and get healthy. There are people with back problems, and you need guidance. And I think that if we could, I agree with you, if we could kind of redistribute our funds in a different manner to boost more healthy roles and decisions for people, that would be wonderful. I think we are also kind of in that mode, kind of profit-based too, just by the privatized community. The latest fad, the latest supplement, the latest medication, makes $1 billion for somebody in 6 months, and then they disappear and that fad is gone. We're on to the next one, right? And so there's a level of education that's missing. I think that is equal to, kind of healthcare and how we handle it. So with with some of the problems, what are other areas that you see that we could, attack? And especially maybe on the corporate side. Again, I think that is a wealth, distribution issue. Where do you see more problems and kind of answers to that?
Although I won't say that I'm a huge fan of government intervention, I think there's some things that the government could do. So one is there are no limits on what providers, I don't mean people, what companies that provide any kind of healthcare can make. I mean, and as you said, a good example is people come on with whatever the latest vitamin nutraceutical is. It doesn't require FDA approval, and they can make there are rules about what they can claim, but those rules are not enforced at all.
Right.
So they sell a bunch of that junk and make a ton of money, and then they're onto another entrepreneurial effort. So these are entrepreneurs.
Yeah. Absolutely.
You think about insurance companies or pharmacy benefit managers, PBMs as they're called. PBMs in particular are so annoying to me because they don't provide anything.
Yes.
But they scrape off, a PBM scrapes off more than 15% of what the drug costs. And
Wow.
so if you think about any drug that you buy at either pharmacy or online pharmacy or wherever, it could instantly be 15% less if we just get rid of PBMs.
Right.
Is anybody going to do that? No, they contribute gobs of money.
Yeah.
So I think putting, and other countries have done this, putting some boundaries around what people can make, what companies can make in healthcare. I mean, the same thing is done with utilities. It's done with all these things that are kind of government overseen programs. Right now, these are not government overseen at all. So as I said, I don't want to live in Singapore, and I don't want my life regulated by the government. But if it's regulating something so fundamentally important as healthcare, I think there's a tremendous amount to be said for that. Yeah. And so that's an area. I will mention also, people will hear about how great health is in a place like Denmark or Norway or wherever.
Right.
It's low cost and they have a great public health system. I had no idea this. I learned that in Denmark, nearly half the people, in addition to that government-sponsored insurance, they have private insurance.
Wow.
It's like a Medicare supplement here. Yeah. I mean, they don't advertise that at all, but that is what is the case.
Wow.
So,
I did not know that. Interesting.
Imagine a world where, or not a world, a country where everybody had access not to, gold-plated healthcare insurance, but to the kind of the minimum.
Yeah.
And think of the VAs, or think of, whatever. But we don't have this number of the population, which, depending on where you live, can be 15, 20. San Antonio might be 30%. The population has zero health care. So what do you do if you don't have any health care? Well, you can't afford it. And so your health declines until you really get sick.
Right.
So, if we had some kind of baseline, and, this is a lot of things I talk about are polarizing to either one or the other side of the political.
Always, right.
but this one polarizes both, because the people who think the government, generally the Republicans who think the government spends way too much money on healthcare, they say, oh, that's just a waste of money.
Sure.
The Democrats say, we're not going to stand for two levels of healthcare, where there's healthcare here for the wealthy and healthcare here. Right. And when I have this discussion with many of my friends, I say, look, they're not two levels. There are already two levels, if not three levels. So one level is commercial, one's government. Then this is a large percentage of people who have no health care.
Yeah.
So, I'm the fun thing I say is, and what I'm trying to do, honestly, my largest goal in this conversation that we're having in my career over the next 10 years, I'm really going to get out of my administrative duties. I've done them long enough. I'm going to start seeing patients again in the VA. But my goal,
Wow, that's great. Usually people do the opposite.
Yeah. Well, our kids are grown and we don't need, a huge income. But my goal is to try to help people understand that even in this world of constant information from AI or from, Reddit is the worst in my opinion.
Oh, gosh.
We need to reestablish, and I'm not saying this pejoratively about other healthcare professionals, but we need to reestablish that trust between physicians and their patients.
Absolutely.
A lot of that's lost, and it's lost now because, and my wife, who actually is a retired physician, she'll come to me and say, well, I read about such and such, and, what you're saying is not right. And I say, well, let me guess, was this Reddit? And it's just whatever. And
it is.
And so anybody these days can say anything they want. And unless there's some way, and I don't have that way, of restoring that trust, I think the trust has been lost with all these changes in healthcare. It's not lost, I don't think, because of predatory physicians making $1 billion. It's lost because of all these other factors that are focusing down on healthcare.
Absolutely. Very well said. And I know we get a lot of flack. We get a lot of accusations about making too much money and especially from pharmaceuticals, they take you to dinner, they take you skiing. I'm like, if you think that makes any difference to my level of care for my patients, I've got a lot more to worry about than that, believe me. And so I have a few more interesting questions for you on this note. We probably will take a short break, but I do want people to know where to find you and your book and all. Just FYI, if you are watching YouTube, you've got the visuals. We are running his website down at the bottom, but also got a QR code in the top right corner, top left corner, depending on how you're looking at it, that takes you straight there. But Dr. Runge, please tell me how people can best find you, and we'll go from there.
Okay. First, it's Marshall, to you and everybody else in the world, my first name. One of the best places to go is a website that was established with Forbes. It's called, it's DR for doctor. It's all one word, DR Marschall, Marschall, Runge.com. So that has a website. It has connections to all kinds of things, but it includes if you want to get in touch with me. I'm not the greatest in getting back in touch, but I do try. If you want to get in touch with me, if you want to find information about the book that was published in May, The Great Healthcare Disruption. So that's the best place to start. My wife says when she looks me up, she finds me doing crazy things on social media. So you can follow that, but that doesn't have the real information you need.
Exactly. No, of course. And so all of that will be on my website, drpbetterlife.com. Hopefully all of you are familiar with that and can find a bunch of great people that I've had on the show, but definitely can find Dr. Runge, Marschall on there. And we will provide that. Plus, like I say, all our great shows, drpbetterlife.com. We are going to take a short break and pay homage to my great sponsor, which is Magna Pharmaceuticals. So just one moment. We'll be right back. I've got some interesting questions for you.
Depression, anxiety, low energy, weakness, these are just some symptoms of low B12 levels. And the absorbable B12 folate supplement that's helping people declare victory over depression symptoms is De Novo Plus B12 by Magna Pharmaceuticals. Patients with symptoms of depression often exhibit low levels of folate and vitamin B12. The human body needs sufficient folate intake to produce the essential neurotransmitters serotonin, dopamine, and norepinephrine. These neurotransmitters alleviate feelings of sadness, anxiety, and gloom. What makes De Novo Plus B12 so successful? De Novo Plus B12 contains readily absorbable folate and B12. That means it's more successful at correcting the root cause of your deficiency, not just the symptoms. Whether you are suffering with low energy, depression, fatigue, or anxiety, you owe it to yourself to learn more at magnaweb.com. That's magnaweb.com. Please let us know at checkout that you heard about De Novo Plus B12 on The Better Life with Dr. Pinkston.
So welcome back. I appreciate everybody listening in. I am with Dr. Marschall Runge, who is with the University of Michigan. And oh my gosh, you've got a laundry list as long as my leg of wonderful things that you've accomplished and done. And thank you for also paying attention to healthcare as it stands at the moment, and hoping to make things better. So you've got the book, The Great Healthcare Disruption, and that's going to be accessible on the website, and we'll talk more about that in a minute. But I do have a couple of thoughts that came across as we were talking. I hope we can speak to it. I'm kind of throwing a curveball at you, but I know now there's a shift in medical care. First of all, I'll say that something, and reiterate something you said, that now anybody can be certified or claim certification or, make claims that they know and understand, a disorder or a process, like nutritionists and trainers or people like that who are, non-physician trained, maybe non-provider trained. And so people can access information from anybody, and you don't know what's true and what's not. And so I hope we can visit with that. But in bringing that up, now there's a different step to getting care in this country, and that are the mid-levels, which they don't like to be called anymore. But I'm talking about physician assistants and nurse practitioners who play a great role. I have a fantastic nurse practitioner at my clinic. I trust him empirically. He's an amazing provider. Not all are, though, but this is concerning to people, and again, may take away a little bit from the physician, patient role. How do you feel about that?
Well, I'll start by saying I agree with you. I think physician assistants and nurse practitioners play an incredibly important role in healthcare, and I think, for example, with nurses, with both of those groups, but with non-advanced nurses, as they're called, there's a real shortage, and we're looking at more of a shortage in the United States over the next 10, 15 years. But importantly, there's a huge shortage in physicians now anticipated, and the shortage is greatest in primary care physicians. So primary care meaning family medicine, general pediatrics, general medicine, general obstetrics. Yes. And that is another big issue. So I want to talk about that for just a moment. If you look at graphics, which I have in the book, that look at the cost of healthcare in countries across the world, we're way high. If you look at the number of primary care physicians per capita, per person, we are way low. We're the lowest. Yes. And sometimes by a factor of, 10 or more. They have 10 more primary care physicians than we have for a given population. So what's the solution there? Well, obviously, we need to figure out how to make primary care more attractive and more people to go into it. We have a general physicians shortage, so that's not going to fix everything. Right. And I think that there are many great models for ways that physicians practice with what I'll call mid-level providers, as you did, or advanced, we call them APPs, advanced practice practitioners. And mostly the ones that I find most attractive are around what we call a medical home. And medical home means that people can go to a single place and they get care from who they need to get care from that day. They frequently have availability of a discount pharmacy. A lot of times they have dental care, sometimes ophthalmologic care, or at least virtual ophthalmologic care. Right. And there are many examples of this. The one that I've practiced in that I find really compelling is the federally qualified health centers, which I think in Michigan there are 38 or so of them. They provide a great medical home. And so why is this so important? Well, everybody's working together. I find out that I have some problem, and they keep up with their patients. So I call them up and say, man, I'm having a terrible cough. And they say, well, come on over. And I go on over, and I'm screened by typically either a nursing assistant or an RN. And then if I need to see a mid-level, they're there and they're available and they schedule that way. If I'm have a blood pressure of 300 over 150, it's a very complicated problem, the physicians get involved immediately.
Yes.
So a lot of the, it's joint decision making. The models, I do think there's a place also, and I've spent a lot of time in rural Texas. There's a place where you can't get a doctor to practice there.
Absolutely.
And they have health centers, particularly, the ones I know best are in the Hill Country, where they have a PA or a nurse practitioner. And they're independent practitioners in areas where we really need that. Yes. So I'm a big fan of that also. So that's where I see this interface. And I think that there's a lot of back and forth chatter about, well, who gets paid, how much they get paid. But generally those professions get paid well. And so I think there's a place for everybody.
Yeah, I agree. And, my, in Texas and, our associations, I won't name anybody, but our associations are actually very, very strongly against, kind of the mid-level entrance and having more and more power, controlled substance, scripts and things like that. And I understand it. But I have, probably over 15,000 hours now in teaching nurse practitioners and PAs, just through my clinic and my private practice. And I love it. These people are very, very hungry to help and provide. They are very excited about what they're doing, and they recognize and know and understand that they are not attending medical school. So they are at a, different level and not a sub-level. I don't want to appear to say anybody's kind of below me, but there's a difference in knowledge, right, and expertise. And so they know where they are. And the greatest thing that I teach them always is, if you don't know, ask. That's all you have to do. If you're in with somebody and just follow that gut that's inside, if it's something that, tells you, I'm not sure about it, you just need to ask. And that is what's great about having a practice, kind of like what I have, is that, Provider Wenzel knows exactly when to ask, and I will intervene at any moment. And, and he is always free to do that. And it works very well. Now, you mentioned the lack of incentives or whatnot for primary care. This occurred back when I was in medical school. There was a huge shortage at that time. And that is when we developed the whole gatekeeper, model, which is an insurance driven.
Absolutely.
That's an insurance thing, a gatekeeper, please. And so I think the model of that as a gatekeeper needs to change, and the model of prevention. Now, I worry about training, and I love this because you're the dean of a medical school, so you can tell me more about this, and I'm a sponge. Please educate me on the training now. Where are we in training physicians on more of a preventative model with nutrition, with fitness, with, weight management, disease management for the future, things like that? Where are we in our training? Because a lot of people complain about them. A lot of people, I think, that don't have the knowledge complain about, well, my doctor wasn't trained to know any of that. So what are your thoughts there?
Well, overall, at the end of the day, it's a good news story. I do want to comment about, now I forgot what I was going to comment about.
Oh, sorry.
Something about mid-level providers, but anyway, maybe it'll come back to me.
And when it does, just let us know. I'm sorry.
No. But I think that we need to evolve. So, for example, I pushed and am still pushing at the University of Michigan that we have a 3-year curriculum for primary care physicians, and that's in multiple fields. And the ones I mentioned before, family medicine, general internal medicine, et cetera. And so people say, well, wait, we're not going to have well-trained physicians. Well, that's not true. And the reason that's not true is when you and I went through medical school, me even earlier, you had to memorize everything. Now it's impossible to memorize. So the skill set is different. It's you have to have a fundamental knowledge, but do you have to have organic chemistry? I'll just go out there and say, what a waste. And it excludes a lot of people from medicine. So there have been now a small handful of medical schools that have gone to a 3-year curriculum. We're seriously looking at this. You have to declare that you're going to go into primary care. And if you do, and we don't have this all set up, I wish we did, but we're working on it. If you do, you do 3 years of medical school, 3 years of residency. And if you then stay in practice, it's a full tuition reimbursement. So one of the problems with primary care is, it doesn't pay very well. And so people end up with a debt of $200,000 or $250,000. I mean, that's like buying another house. So I think we need to think hard about how to do it.
Right.
The last thing I'll say about this, and I'll let you know if I remember what else I was going to say, but
Pleasure.
Universities in general and medical schools in particular, universities in particular and medical schools in general, trying to affect change is so difficult. So difficult. People just don't want to change. And there are 1,000 voices that say, no, we can't do it that way. We can't do it that way. And I read a book that was given to me recently called Whatever It Is, I'm Against It. I mean, that's the title. Whatever it is, I'm against it. And it was written by a former university president, but it's so true. And so I think but taking that bull by the horns is really difficult. And as I've tried to make changes to work toward this 3-year curriculum, to do some of these other things we've talked about, George Bush had a phrase, 1,000 points of life. There are 1,000 points of no.
Right. Absolutely. Because I know, and we used to call it the good old boy system. Well, I did it this way, so you're going to do it this way. Right. But we've done we could go on all day about, the difference in work ethic of our generations now. And it's not necessarily bad. And thank God my son never practiced in a different era where he would be so rubbed the wrong way by the system as it is. But, I'm hoping that he will be one of those that takes it and makes some great changes.
I remember what I was going to say.
What is it? Yes.
So another positive for the future is that what I see in our medical school, and I think people see everywhere, is we went through this era where everybody wanted to figure out, well, I want to be a doctor. I want to join the country club. I want to make as much money as I can. I mean, not everybody, but that was a common view. I think the current generation is more interested in improving health. And so I think they will be much more amenable to your voice, to the voice of people who say, let's think about how do we improve health?
Exactly.
And maybe even rebrand ourselves. Maybe we're not healthcare providers. Maybe we're health encouragers. That's a terrible word.
No, but you're on the right track. I agree with you completely. I do. I see that change in the generation. They are really more footed to think about the better of people rather than the bottom line dollar. And I know you and I went into it for the right reasons, and so many did. And I'll add on just to that. The things that I did or did not learn in medical school is not always the responsibility of all the faculty and people that I ran into. I got a great education. I got great training. I got out. There was still a lot, especially like in the weight loss and nutrition area, that I did not know. But you know what? That's my responsibility as a physician to keep learning.
Yeah.
Change, right? You get a new decade and things change, and that is my responsibility. So physicians are responsible to continue their education outside of that and their knowledge base of everything. So don't forget, if your doctor doesn't know something, it's their responsibility to say, I don't know, and go learn it. And that's important, right? I figure you agree there. But, Dr. Runge, thank you. Marshall, thank you so much for being on today's very enlightening conversation. I appreciate it. You're very humble, very gracious. I love this book. I think everybody needs to read it. I think it'll give you a good, strong base about positivity for change in the future. I do think we can do it. I felt like I've seen a tide over the last couple of years of change. It feels positive. So I'm hanging on to that. And you were part of that. Thank you. Is there anything else, any other thoughts, anything we missed that you want to add on here?
Well, I would just say I feel a common spirit with you, and I think we could talk for hours.
Right.
But I think we hit some really important topics. I'll mention one last thing that I didn't think about. So people are always going to online sources for healthcare advice. And most of those, there are just a few that are any good.
Absolutely.
And WebMD, for example, or up-to-date that doctors and healthcare providers know about. And I can't believe these words are going to come out of my mouth, but I think the closest thing to good advice about healthcare these days is through AI, so ChatGPT or Gemini or whatever you use. And they have clearly, when I look up something, it says, this is, where the field is, and they're usually quite accurate. And they say, but you should talk to your physician.
Yes.
This is not medical advice. And that's like a world away of what you'll read in these other sites where people are, people who with no medical training are giving you advice. Right. So
be cautious.
I'll say that's one of the areas in which I think AI can help us with health as we move forward.
It does give you an idea. And I ask it, I do it too as a physician.
Yeah, me too.
Right? I can get some great studies to pop up of things that I need, but I always ask it too for the specifics of what I want. If I want something more integrative, if I want something more contemporary, whatever it is, just be specific, and it does hand that to you. But please, in all aspects, make sure the people that you're talking to are truly certified and studied in what they're doing, and just learn. Keep your knowledge base open and your mind open, but go talk to your doc that you trust, please, and keep that. I think patients are responsible too for keeping that trust going. I've learned my position with patients has changed a lot. They come in kind of already educated and already kind of know what they want and think they know what's going on. And so sometimes my trust with patients is don't assume everybody's done that. Just let's have a conversation about what's best for you. I'll give you all your power to make your decision for yourself, but please trust me again then, and we're working on it. But thank you so much for being on today. Where can people find you? Tell us again.
They can find me, the best place, I think, is through the website for the Great Healthcare Disruption, and it's DrMarschallRunge, all one word. That's drmarschallrunge.com.
Yes.
And if you don't, it has virtually everything a person needs to find out about me, about contacting me, about the book, etc.
Yes, and that will also be on my website at drpbetterlife.com, and as well as many other great shows. I've been doing this for almost 3.5 years now or so, and it's been wonderful. Right. So there's a lot there. But thank you again for appearing and talking with me, everybody. I hope you have a fantastic week, and as always, please take care of each other out there.
You've been enjoying The Better Life with Dr. Mary Ann Pinkston. For more information, go to drpthebetterlife.com. That's drpthebetterlife.com. And listen next week for The Better Life with Dr. Pinkston.